So this talk is going to focus on the ankle plantar flexors, which play a key role in functional tasks like walking, running, and stairs. We're going to focus on first just understanding the anatomy, and from there getting an appreciation of what their moment arms are. We'll start with this sagittal plane image of through the middle of the ankle joint. So we'll start by labeling the bones. So here's the tibia, and this is the talus. This is the trochlea of the talus, which articulates with the mortise of the tibia. And then we see the calcaneus here in cross section. So now we can label the muscles. This dark line is the Achilles tendon. This is the soleus muscle attaching to it. And then we have Tom, Dick, and Harry as we go closer to the tibia. So this is the flexor hallucis longus, flexor digitorum longus, and tibialis, a posterior muscle. So the axis of rotation of the ankle joint goes through the center of the trochlea of the talus, approximately where my cursor is right now. So if we look at a cross-section MRI through that spot, which is what we have to the right, we could start to look at where those muscles sit relative to the axis of rotation. And so here's the approximate axis of rotation passing from one malleoli to the other. And then we can see the muscle tendons and bellies here posterior, and then the Achilles tendon most posterior here. And this is anterior to the leg. If we move from lateral to medial, we can label each muscle. This is the fibularis longus tendon, fibularis brevis muscle that will turn into a tendon shortly, the flexor hallucis longus muscle, and the tendon starting to emerge right where the cursor is. And this is the flexor digitorum longus tendon and the posterior tibialis tendon. What we can see is that the moment arms of the tendons lying close to the bone are much shorter by a factor of 2 to 3, perhaps 4, than the Achilles tendon here. And so this table represents the data from a muscle architecture study that documented the different PCSAs of several of the muscles of the leg. And here we have kind of an estimate of their moment arms. And we can see that, as we just stated, the gastrosoleus moment arms are around 4 centimeters, and then the rest of the muscles are somewhere in the 1 centimeter range. So approximately 4 times larger relative to moment arms. And then because of PCSA, taking into account fiber angle, or pennation angle, and fiber length, we can see that the soleus muscle is an unusually powerful muscle with a total PCSA of 52. And the medial gastroc comes in second on this list with 20, and then the lateral gastroc 10. So total PCSA of these 3 muscles is around 80. If we compare that to the these 5 other muscles that also sit posterior to the axis and are classified as plantar flexors by the anatomy, we can see that their PCSAs aren't as significant and only sum to about 42. So the combination of a high PCSA and the triceps surae, which is the gastrosoleus muscle, and moment arm gives it an estimated contribution in terms of an ankle moment of around 32 newtons per centimeter, and with the other plantar flexors only contributing about 41, so several times higher in terms of power. So an Achilles rupture, for example, you lose all of this power, and even though you have other synergists which assist with plantar flexion, they can't generate nearly the power, even if they were to hypertrophy, to substitute for the gastrosoleus group. So in summary, the dominant plantar flexors of the ankle are the gastrosoleus group because of their PCSA and moment arm. And the other muscles that we talked about, the FHL, FDL, posterior tibialis, fibularis longus, and brevis, are going to not have a primary function at the ankle, but rather have a primary function at the subtalar joint or other joints of the foot. Another detail about the pull of the gastroc soleus groups is its action on the subtalar joint. So if we recall this picture when we were talking about the subtalar joint, we noted that the axis of the subtalar joint was oblique and started laterally and then deviated about 15 degrees medially where it passed through the anterior part of the joint. Well, if we start to imagine, well, if the Achilles tendon inserts here, then it's on the medial, it's just medial to that axis, so it could be an inverter. In other words, pull this way. But then we could also start to imagine, well, what if it starts an inversion, if it's already, or it starts an eversion, what direction would it pull the subtalar joint? And so it's going to turn out to be important. The pull of the Achilles tendon is central to many theories of the foot, and understanding this action at the subtalar joint is going to turn out to be important to us later. So here's a graph of the moment arms of the Achilles tendon at different levels of activation. So we can ignore that right now because the activation really didn't make a big difference. And then we can see here, so when it's positive, this is an inversion moment arm, and this is the length of the moment arm. And this is an eversion moment arm, and this is its length. And this should read 12 and 16. So it'd be 4, 8, 12, and 16. And then here we can see the different ankle positions that the person's been placed in before measuring these moment arms. So this is 15 degrees of eversion for both the medial and lateral gastroc. This is neutral position for the medial lateral gastroc, and this is 20 degrees of inversion. We can see that in general they're the same, so even though we can't see the medial gastroc, we can assume it's the same at 20 degrees. And so essentially what's happening is as we move the person into eversion, there's a tendency for the gastroc pull to pull the subtalar joint into even greater eversion, or in neutral, there's a slight moment arm toward inversion, and then when it's inverted 20 degrees, it pulls quite strongly into inversion. So the bottom line is that the gastroc will pull the subtalar joint into whatever position the subtalar joint is assuming, with a neutral position and being biased toward inversion, but that pull will become stronger if the subtalar joint's in inversion, and then it'll become stronger toward eversion if the foot's in eversion. So in summary, the Achilles tendon force is very high. Note the high PCSA and the soleus, and mostly contributes to plantar flexion, but it also contributes to both eversion and inversion depending on the subtalar joint position. And so now we want to switch and talk about the tendon dynamics themselves. And this will be one of the first times that we connect the tissue responses in terms of how much the tendon stretches to a disease, which is Achilles tendinopathy, which is shown here to the right. So we have a normal looking tendon here on ultrasound imaging that has this kind of gray speckle pattern, which is the collagen fibers arranged along the longitudinal line of action of the muscle. And then here is an Achilles tendon, which is kind of sagging a little bit and has a large defect here where the collagen fibers have become disorganized. And so we want to understand the tendon dynamics, and that'll give us some insight into what happens with people who have Achilles tendinopathy. So just reviewing and thinking about tendon responses, one of the key reasons we started studying the biomechanics of the tendon is we noted that there's something called the stretch shortening cycle, which normally occurs during gait and hopping and athletic activities. And basically what that stretch shortening cycle includes is just before landing, there's a pre-activation which shortens the muscle and tenses the tendon. And then on landing, there's an elongation of the muscle, and that's the stretch cycle, the stretch part of the cycle. And then if we don't relax at all and immediately move to a shortening contraction, we would go into more plantar flexion in this case. We would have an augmentation of the muscle contraction by release of the spring of the tendon. So the tendon's stretching here, and it's acting like a spring when it goes into plantar flexion and returning that spring energy back to the muscle, which contributes to our movement. So let's see if this really occurs in vivo, and this is an experiment that was done just recently in a person that was hopping. They had this kind of fancy setup here where they had an ultrasound probe that was tracking this part of the Achilles tendon. This is the soleus muscle here. This is the gastrocnemius muscle. This is the Achilles tendon. And then they also tracked the distal end, and then they could get how much the tendon length changed. And that's not easy to do. This is a unique experiment. And what we can see is that the tendon length change is tracked here as the person was hopping. This is the force on the force plate, and this is time. And each one of these dotted line marks a hopping cycle. So they hopped on the leg, hop and hop. And we can see that the tendon length change was approximately 20 millimeters. And so a fair bit of stretching in the tendon is occurring. When that's expressed as a percent of the length of the tendon, basically here's some of the peak strains that occurred, and then the estimate of the return of the spring energy to the movement. And so we can see that the tendon strains, the highest one was one person had a length change of around 11% of their tendon length. And then we had other ones that were as low as 4%. And what we can also notice here is that basically the ability to hop was significantly enhanced with just the passive recoil of the tendon contributing up to 24% of the energy to the hop task. So is this important clinically? Well, this is a study done in Los Angeles by a famous muscle biologist named Reggie Edgerton. What he did is he measured the strain, so this is a strain graph of volunteers before putting them in the hospital for 4 weeks on bed rest, and then remeasured the strain immediately after bed rest, and then immediately after an 8-week physical therapy exercise program. And so this is actually stress and strain curve. And so we can see that the stiffness of the tendon here and what it is. And we can see the black is before the suspension in the hospital bed, and then the red is immediately after suspension for 4 weeks. And then the 6-week follow-up after the physical therapy, the stress-strain curve returns to normal. So what does this tell us if the strain after disuse, basically? What's happened is that the compliance of the muscle has increased. So rather than getting stiffer, it's gotten less stiff or more compliant. And what we've noted both in the lab at USC and in some of the research at Ithaca College that we are just now publishing is that in patients with Achilles tendinopathy, they react more like the disuse pattern. So in other words, the tendons aren't more stiff, they're just the opposite, they're more compliant. So they give more or elongate more, which is what we're seeing on the X here, per unit of force that's applied. And so the new theories that have to do with Achilles tendinopathy are looking at trying to connect different treatments that restore tendon stiffness as a result of exercise.